Good afternoon. This is Bob Johnson, CEO of Remedy Medical Services. We appreciate you joining us for this webinar, Critical Access Emergency Department and Hospitalist Program, A Journey to a Partnership, presented by Mr. Tim Richmond, CEO of Wheaton Franciscan Elmbrook Memorial Hospital in Brookfield, Wisconsin. Before we begin, our introduction to Mr. Richmond, a couple of things, some housekeeping issues. If you're using your computer speakers, please mute your microphone by clicking on the microphone icon on your GoToMeeting control panel. If you're calling in via the cell phone, please be sure to mute your speakers also. If you have any questions, feel free to list them in the chat box towards the bottom of your control panel, and we can address them at the end of the presentation, or you can ask questions of Mr. Richmond at the end of the presentation, or simply by unmuting your speaker. Mr. Richmond may pause to ask for questions as we go. This is the first in hopefully a series of webinars that will connect you, the leaders of critical access medicine, with the goal of sharing ideas and out-of-the-box solutions to address the spectrum of issues specific to critical access facilities. And now it's my pleasure to introduce Mr. Tim Richmond. Mr. Richmond is president of Ascension South West Market, including Wheaton Franciscan Ascension Elmbrook Memorial Campus, Brown Deer Campus, Wauwatosa Campus, and St. Joseph's Campus. Tim has a long history of service to the legacy ministries that have joined to form Ascension, Wisconsin, and he's a dynamic, hardworking leader with a clear vision to help shape patient care in the South region of Ascension, Wisconsin. From 2008 to 2016, Tim served as president and CEO of Calumet Medical Center, Hospitals, and Clinic in Chilton, Wisconsin. During his tenure, he increased overall revenue by 38%, and under his leadership, the hospital campus was rebuilt and major renovations were made to the on-campus clinical spaces. Calumet Medical Center was listed in the top 100 hospitals by Becker's Hospital Review, and twice Tim has been named top 50 critical access hospital CEOs to know, also by Becker's. Now as president of Ascension Southwest Market, Tim is responsible for all areas of hospital operations. He provides visionary leadership and assists with recommending policies and procedures to ensure efforts to provide consistently high quality patient care and support the mission of Ascension, Wisconsin. Tim has served in several leadership roles with Wheaton Franciscan Healthcare, including Regional Vice President, Rehabilitation Services and Cancer Care, Vice President, St. Joseph's Regional Medical Center, Vice President, Covenant Rehabilitation Services, and Executive Director, Rehabilitation Institute of Covenant Healthcare. He's also held leadership roles at Sacred Heart Rehabilitation Institute and University of Wisconsin-Milwaukee School of Allied Health. Tim received his bachelor's degree from the University of Wisconsin at Madison and a master's degree in healthcare administration from Cardinal Stritch University in Milwaukee. Please welcome Mr. Richmond, and Tim, the board is yours. Thank you.
Thank you, Dr. Johnson. Well, good afternoon, everybody. I'm going to keep this as simple as possible, and as Dr. Johnson mentioned, you can either type in your questions or at the end hold them and we can have a little dialogue. When I was asked to speak to this subject, I'm really going to pull from a 9-year journey of many ups and downs related to the ED at Calumet Medical Center where I worked. Ups and downs, mistakes, learnings, successes, and I hope to share some of those today, and hopefully those of you on the phone today will be able to pick up a nugget or two, and at the end of this maybe I can also learn from you. Obviously the emergency room in a critical access hospital, in any kind of hospital, is one of the most important parts of your whole facility. Many consider it the eyes and the soul to your community, because most of the community gets exposure to your ED prior to anything else. A little background information about the hospital that I drew my experiences from. Calumet Medical Center is part of Ministry Healthcare, also now acquired by Ascension. It's located in Chilton, Wisconsin, in the Fox Valley in central Wisconsin. Chilton has a total census of about 5,000 citizens. Its catch basin is about 25,000. It is the only hospital in Calumet County. To level the playing field a little so that every one of the folks that are listening on the phone, executives, physicians, to give you a little backdrop so that every one of your hospitals that you're listening from today, I understand has a little bit of nuances, different things. But I started with the assessment that you're looking at on the first PowerPoint, the assessment related to the medical staff. And a couple of things that we were able to establish was general surgery 4 days a week, orthopedics 4 to 5 days a week, and our ED was, over the 9 years, able to start working with these two groups, these two specialty groups, to actually put people, the physicians in the ED and the providers in the ED could call the specialists and look to tuck people in if it could be held for the day, or refer them out to a tertiary center. Also on the medical staff, I was very fortunate to have a Vice President of Medical Affairs, which was a family practitioner that had 30 years plus, and the partnership that I had with the Vice President of Medical Affairs, executive and doctor, throughout this whole presentation, without having a partnership with somebody that had practiced and was a big part of the medical staff, none of this would have been possible. As far as the volumes go at Calumet Medical Center, the hospital that we're talking about today, in terms of the experiences, it was around 5,000. When I first got there, it was closer to 4,000. It's still growing today. The learnings that I have that we're going to talk about today really apply to anybody between 5,000 visits and 10,000 visits. We all share difficulties in staffing that with nursing, trained staff, and providers. The other important factor that all of you are aware of is the support of other hospitals in your catch basin in your area. Calumet had a hospital in the system, a sister hospital, St. Elizabeth's in Appleton, which was 26.8 miles away, which proved to be a very, very important factor in any success that Calumet had. The other important factor is all of you have different forms of transportation. We were able to establish at Calumet air transport with ThedaCare out of Appleton, and we owned our own ambulance service. So we had 2 ambulances. I know many of you probably contract. Obviously, the most important factor here is door-to-door and getting people from the field to your hospital, stabilize and move on or keep. So that's really the backdrop, and that was these 4 categories in terms of when I first got to Calumet in 2008. These are the things I looked at, assessed, and if they were not up to par, I built on them. Maria, I'm going to go to the second page, the metrics of success. Obviously, in today's medicine and today's healthcare environment, we're all held to a tremendous amount of metrics. And one of the biggest one is patient satisfaction. And simply put, if people have a bad experience in your emergency room, it can influence their whole perception of your hospital and facility. And just the opposite is true as well. And I will go back to this a couple times. I always kind of gauged everything on if I was using the ED, or my wife, or my kids, or my neighbors, or my mother, how would they experience it? And that would be my biggest gauge of success. But obviously, you all have different vendors that work and keep track of patient satisfaction. One of the most important factors that we put into place at Calumet with Remedy Medical Services, and we tried it with 2 other companies and it wasn't very successful, but with Remedy it was very successful. And I'm sure many of you have heard of this before, but it's the simple 5 letters, AIDET, A-I-D-E-T, AIDET, which is a Studer learning. And I will go through that very quickly, but when we put this in play, this AIDET, as an exercise that we expect out of all of our staff, including the providers, this made a tremendous effect on patient satisfaction in a positive way. So AIDIT stands for, A is for acknowledge, so that no matter who you are, and when you go into a room in the emergency room, there's a patient and family in there, that you acknowledge them. That could be maintenance, that could be housekeeping, that could be nurse, provider, but you acknowledge the fact that a patient's in there. You introduce yourself, especially for the physicians and advanced provider, introduce yourself and a little bit about yourself. Same with nursing, same with the rest of the staff. Durations, D for duration. How long is it going to be? So if the physician orders an x-ray and there's a backup in x-ray, well then it's 45 minutes, and let's tell the patient and family it's going to be 45 minutes. Studies have shown that if you give the information to the patient, they'll be comfortable. If you don't, it seems like an eternity that they've been waiting, and obviously it affects the patient satisfaction. E is education. The minute that the patient comes into the ED in your facilities, we begin to educate, we begin to train, because we're going to never do something to the patient, we're going to do something with the patient. And the last, the T, stands for thank you. And it's something we in healthcare sometimes forget. So again, AIDIT, A for acknowledge, I for introduction, D for duration, E for education, and T for thank you. Seems very simple, but we went as far at Calumet as to videotape our teams. We videotaped them and gave them a chance to look at what it would be like to experience care from themselves. And this made a big, big effect down the line. The other thing that we did around patient satisfaction was we formed teams and had a team approach. Really truly believe in the Studer models, but one of the things that worked very well in the small facility that we had was a nurse and a doctor, when possible, would go into the patient room and both work together, both asking many of the same questions. When the physician left to go to another room or go to charting, the nurse was able to ask the questions, did you understand, doctor? And we found in the first year, we found that in 38% of the time, the physician and or family did not understand the doctor. So the doctor had given very clear information, but maybe the family and patient were stressed, or maybe a pain was a factor. But at the end of the day, the nurse was back into the room several times and was able to ascertain what knowledge they had. This allowed the nurse to either do it herself or himself, or go get the physician, and we called that real-time recovery. And many times they would just go get the doctor, and the doctor would repeat the information, which was a real patient pleaser. Teamwork in the ED, well, I think there's no place in a hospital that teamwork doesn't come into play, but one of the things that we had to do was really set some very, very formal expectations of our nursing staff, and I won't bore you with the training and the actual metrics, but we had to really lay out some expectations for our staff that around AIDIT, around teamwork, dyad, and communication. As I said before, we videotaped our teams several times, and for new staff we do the same. And then lastly on this page, related to metrics of success, organizational fit. It's a challenge in a small facility, critical access rural facility. Either it's feast or famine. Either you have a full facility and tremendous amount of acuity, or you go through periods of time when there's not much there. And obviously staffing and finding providers is really important. But one of the things that I would encourage all of our listeners, that if there's administrators and executives or staff on the phone, try to see the experience that your providers coming into your facility. So if you have an external provider, or you have someone coming from your own medical staff staffing your ED, one of the things I did was I actually pulled a 24-hour shift with one of our physicians, and it really gave me an idea of what they see. So everything from food, lodging, sleeping quarters, place to exercise, a place to go to relax, all these things came into a factor, and I will address them a little bit later. But the exercise that I went through in terms of trying to experience, because most of the physicians that were staffing and advanced practice providers that were staffing at Calumet were coming from a far distance away. So in essence, this was their kind of home away from home for their shift, whether that was 24 hours or 48. And Maria, let's go to the next slide. There's a lot of studies done around 24 and 48, and when I get to the end of the presentation, I'll show you what we ended up. We actually ended up with a 4-day rotation, which was a remedy idea, which is an awesome idea, and really helped us a lot at Calumet. But for probably the first 5 years of my career at Calumet, we were running 24 and 48-hour shifts with 2 external vendors. Studies will show you that after 24 hours, performance is diminished. But in many times we didn't have a choice. We were short providers, or the vendor that we were using was short providers, and we couldn't find anybody to get, so we had to authorize 48 hours. There's a lot to be said that if you don't have to do that, it's a good idea. The other thing that's going on in the state of Wisconsin is it's estimated that there are between 50 and 90 available MDs, DOs that are in the pool for MCare, Remedy, Infinity, whatever vendor, ED vendor, in terms of staffing rural hospitals. You're really pulling from a very small pool of people and experts. And so obviously, as I go on in the presentation, how we address the 24 and 48 hour, and also what's right, what's safe, and what's necessary for you to staff. The second bullet point on this slide is something that Remedy Medical Services out of Eau Claire came up with, and at first I had a lot of questions about it, but it's a 4-day rotation where a physician and a advanced practice provider comes to the facility. So they're going to stay with you at the facility 4 days. The things that happened prior to the 4-day rotation with the other vendors were all pretty much resolved when we went to the 4-day rotation. Things like handoffs between doctors, handoffs between primary care and ED, communication between specialists, discharge planning, med errors went down. It also, addressed the factor that we were always, kind of subject to weather in the winter, which we have, 10 months of the year in Wisconsin. Snow and ice, and you've got somebody working a 48-hour or 24-hour shift, and then you have an ice or snowstorm, it presents problems for a smaller hospital. The model that Remedy used that was implemented at Calumet, it really relied on mid-levels and or as they like to be called, advanced practice providers, MPs and PAs. As a matter of fact, in our journey with Remedy, we went not only from an ED perspective, but they also staffed our hospital unit as hospitalists. So we went from 1 physician and 1 mid-level to 1 physician and 2 mid-levels, and they were taking care of the ED and the hospitalist. And all the things I talked about earlier, handoffs, discharge planning, in this model just got better. And that wasn't us gauging it, it was external objective evaluation, and our patients also were telling us that. Maria, let's go to the Calumet Medical Center stage. For those of you that are living or working in the smaller communities in Wisconsin and staffing critical access or smaller rural hospitals, it's pretty hard for any of you to go anywhere, whether it's Walmart or church or wherever you're going, not to hear from the community. And I certainly, when I lived in Chilton, always heard about positive experiences in the ED, and I heard about negative experiences in the ED. And I was quick to realize, how important, how much emphasis I had to put on making sure our ED at this small little hospital in Chilton was operating at its top capacity and top performance. And it really kind of set, I will say, in the journey for that little hospital, it really set the tone for the rest of the hospital. It also was an attractor of other medical staff and other specialists. In the 9 years, there were 3 models at Calumet. One was an independent contractor, external vendor. Problem with that model is that the providers weren't really interested in, other than medical care, patient satisfaction, teamwork. They were more interested in, I'm going to put my shift in, I'm going to be reimbursed, I'm an independent contractor, and I'm going to leave. The second model we had was with a larger group, very good group, but basically they were used to PPS hospitals and larger hospitals and had a lot of difficulty understanding the nuances of a smaller rural critical access hospital. It was costly and it really wasn't where they wanted to be, and at the end of the day it wasn't where we wanted them to be, so that didn't work. And then the third model that we had was with Remedy, and as I alluded to before, we started with them in the ED, and it evolved to not only ED, but also our 25-bed inpatient unit with a census of about 6 to 8, and they were able to staff both. And when we worked through that model, it turned out to be a very, very, very positive thing for our hospital. The key findings, if I look back on this, as I alluded to earlier, I really looked through the lens of how the Remedy providers, what they were experiencing in a 4-day. So we were able to do things like create an apartment for them in the back of the hospital, which we could put through the cost report. We were able to put in some laundry. We had a cleaning service with our housekeepers. We were able to put in a refrigerator. We were able to address some food needs. These are really, really small things. But for a provider that was coming to stay with us for 4 days, we really wanted to make it their home away from home. And that was also reflective in terms of the behaviors, and what I heard back from the Remedy providers was how pleasant it was to come. And we also made them part of our team. So I really kind of look back on this as right out of the box, looking to anybody who's coming in, whatever vendor you're using, I would recommend to you to make it a partnership from the beginning, not solely a business relationship where, the only thing you provide the service and then you leave and I don't really care about anything else. The reality is if you establish a partnership with whoever's providing that important service, it will reap and harvest a lot more benefit. As I indicated earlier, we really took a hard look at what a person would experience coming to Calumet, and we really tried to make a concerted effort to provide the folks that we saw as crucial to our success a good experience with us. At the end of the day, where we are, today, where they are today at Calumet, it's performing at a very, very high level. It's financially successful. It gets rave reviews from the community. It is a consistent model, and then when I say model, 4-day rotation. And even if you're working with a 4-day rotation, whether it just be the ED or the hospital unit together, either one is very positive. And I always judged it, as I said earlier, if it was myself or my wife or my family using this, how would they experience it? Last thing I would say, in all the learnings and all the successes and failures it took to get where it is today at Calumet, it was what I termed a journey with a partner. So when I first started working with Remedy, we kind of looked at it together, not individually. And I took ownership in their success, and they took ownership in our success. And at the end of the day, it's about treating each patient one at a time in a very personalized, compassionate way. I'm gonna stop there. Maria, if there's any questions or anybody that's on the phone that has questions, I know I skated through some of these things pretty quickly, but I just wanted to give you a feel for some of the key components around what I thought was a successful journey.
Well, one of the questions that's in the chat box, Tim, says that you mentioned that you had an 8-year journey to achieve your goals at Calumet Medical Center. At what point in that journey did you start to see the fruits of your labor, and what milestones were you looking for that indicated you were achieving your goals?
A great question. Well, when I had the first 2 models in the larger PPS group and the independent contractors, there were times that I was at the hospital at 2 in the morning knowing that I wasn't going to have a physician because the vendor couldn't provide me a physician the next morning. So that was certainly gut-wrenching, knowing that, at the next shift at 8 o'clock, I had no provider. And the way the credentials worked in the Affinity Ministry system, I couldn't put one in there. So I would be diverting. So that was easy for me. That was my low mark in terms of benchmarking the low water mark. When Remedy came, they came at about 5 years into my 9-year journey. When Remedy came, I liked the way they approached it, and we approached it together from a partnership, and we also looked at ways to set expectations of one another. So your question about how did you know you're successful, we actually worked out a compensation model that we thought were achievable goals, not just withhold money, but whether it's patient satisfaction or completion on charts, signatures, communication. We actually put revenue compensation tied to some of those metrics, and so both sides were had expectations, and both sides would, if somebody was not achieving those, if it was one of the providers not achieving that, the VPMA and the medical director from Remedy Medical Services would work with that particular provider. We never looked at one another with a finger pointing. We looked at it, how do we achieve? And so the other components were pretty easy. Our patient satisfaction scores went up immensely. They went up 20% points. We started pretty low, but I was less worried about spikes and more worried about a consistent trend. And if you look at that today, door to door, our transport to tertiary hospital, our patient satisfaction, our financial success, all these were marks that improved vastly. So I would say between the 5 and 7 year mark, we really started to hit our goal. If I would have been with Remedy earlier, I think it would have probably been earlier experience. Hope that answers the question.
John, I have another, John, sorry about that, Tim. I have another question from John. He's not able to get through in the chat box, but he wanted to know how long did it take to integrate your staff with the Remedy staff? How long did that cohesion taking place, how long did that take?
When Remedy came versus the 2 previous providers, and let me be clear, the 2 previous providers had good doctors, but they just had, the companies had different expectations than what I thought was the right fit for us at Calumet. A lot of times our nursing staff, our medical assistants, our unit secretaries really pretty much blamed any patient satisfaction or anything negative. They blamed that on the medical staff that was visiting and providing services. Almost in my early days, it seemed like a scapegoat. And they took the nursing staff and the allied health staff, they really took little ownership. And we really had to address that with people who really wanted to work in our ED. So some had to move to different places and basically leave our organization. But when Remedy came, we really started to approach some of these team dynamics. The nurse and the doctor going in at the same time, hearing the history, seeing the work, seeing what's needed, a huddle outside the room with doctor when possible. Obviously, if the ED is completely busy, some of those times we can't do, but when possible, after the initial visit, the 2 professionals talking to one another about what they heard and what are next steps. That has never, as far as the question goes, when you stop working with the nursing staff or medical assistants or the ambulance staff or your unit secretaries, the minute that you let up on the gas in terms of expectations around team, so the attendance at the department meetings, going through the patient satisfaction scores, going through all of the AIDIT, occasionally doing audits. I had the chief nursing officer always doing audits on a quarterly basis, watching the staff. If you let up on any of that, it seemed to slide. But, the president there today, Miss Jenny Dirks, a very, very good president. I know she's still diligent about keeping track of how our teams are performing in that area.
I've got one more question coming through. How did you find the Remedy program using physician and advanced providers working, and how did they fit in with the team?
You know, I'm sure many of you are currently in your medical staffs and in your departments, you know, have the advanced practice providers, whether that be in urology or primary care, or wherever it might be. But the Remedy folks, PAs and MPs, for the most part, came with a lot of experience. The ones that were coming, you know, at the end of my journey at Calumet, we were bringing in some new ones with Remedy and jointly kind of recruiting, if you will. But at the end of the journey, we were bringing in some new people, and I was very impressed with how the mentorship was going under their medical director, our shared medical director from Remedy at the hospital. And then how our VPMA also helped on the hospital unit and in the ED to a certain extent in terms of education. So, I mean, I personally, I currently have 3 hospitals and 1 intermediate advanced and 1 very, very large inner city hospital. And I am going to be looking to utilize nurse practitioners and PAs in the existing groups I'm working with right now. I just think it's a good model. I think the reality of the picture is there are less and less physicians available, and there are more and more mid-levels, if you will, nurse practitioners and PAs available. And as long as we have the right training and the right protocols, found it to be very successful. And I also would tell you that our orthopedic surgeons, there were 2 of them at the hospital, and our general surgeon had a lot of trust in the advanced practice providers from Remedy.
I don't see any other questions in the chat box, but if anybody would like to unmute their phone or speakers and ask a question, please feel free to do so right now. Did anyone else have any questions?
So this is David Miller. Can you hear me?
I can.
Yeah.
So we're from River Falls Hospital over on the western side of the state, a critical access hospital as well. We found your conversation to be really spot on from the various Studer and quality components. Question that we have, and you may have said it, but maybe I didn't pick up on it. The physician that you have on duty, they're covering both the emergency department and also providing hospitalist service with support from nurse practitioner or PAs. Is that the model?
Yeah, you know, if you look at it from a 4-day rotation, and I'm speaking it from the administrative role, looking outside in, 4-day rotation, the team, two advanced practice providers, and 1 doctor. The doctor was usually working the day shift, but would go to the apartment 50 yards behind the hospital and was available 24/7 if need be. So you would have a person in the rotation, a mid-level coming on after the doctor in the ED in the evening hours. You'd have a mid-level that was on shift during the day and available for evening hospitalist services. But the 3 of them would rotate. But you know, from a compliance perspective, from a safety perspective, you always had access to a physician. I mean, there was always a doctor 24/7 in the Remedy stable available if need be. Does that answer the question?
Yeah, that actually helped. Kind of sequence. A follow-up question then too: are the physicians family practice docs, internal medicine, or are they trained in emergency medicine? How are their board certifications?
Yeah, the Affinity Medical System, which it was before, as it became Ministry and Ascension, the Affinity System, 3 hospitals, Mercy, St. Elizabeth's, and Calumet. I mean, the credentialing was one of the more difficult things, in my 36 years, but because the credentialing was very, 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 very stringent when you were in that system. So you had to have 2,000 hours of ED time before you before you could come into any one of those hospitals. So if you were a family practitioner, an internist, anesthesiologist, whatever you were, in the credentialing process for Affinity and Affinity alone, you had to have 2,000 hours. You couldn't get those 2,000 hours with us. You had to come with 2,000 hours. And the majority of the physicians that I worked with, and obviously Dr. Johnson's on the phone and Maria, but family practice doctors that were now really dedicating their career solely to emergency room care.
That helps a lot. I appreciate that input. Thank you.
You're welcome.
Are there
How's the
any
weather
other
over there, Dan?
questions?
Sunny and 85 in River Falls.
Yeah, that's what I was thinking. Yeah, I'm on my way.
Exactly. That's fake news.
Hello. Hi, it's Bob Johnson. I received a question here from someone listening but wasn't able to get through. They were wondering about how any of these issues fit with the Affordable Care Act and whether or not this was going to be a problem going forward and what changes might be in the making for hospitals in terms of compliance. I couldn't answer that question, but maybe you folks could.
Well, I'll take the first stab. Obviously, the Affordable Care Act is a large piece of work. It's thousands of pages. But from a compliance perspective, the model that we were having at Calumet, running through the cost report and using all of the aspects of critical access hospital, I see nothing on the horizon that would be negative or be adverse to the current model that we have. Obviously, any relationship these days we have with physician partnerships is reviewed by legal, but unless somebody else has another piece of knowledge, I don't see anything on the horizon, even with the President Trump first kind of flashes around critical access. But I don't see anything negative.
Also, if I could kind of toot my own horn here, the model that we were trying to work for was one that assured that patient care had direct oversight, by a live physician, not a dead one, but I mean, as someone who is physically available 24/7. And I think that's one of the things that kind of separates that model from other models utilizing associate providers. Then I think at the end of the day, the patients also appreciate the idea of having, because in the model that we were trying to create at Calumet, we wanted to have consistency and the patients see a team approach with the doctor and the social provider. And a lot of the people, especially in smaller communities, look at the doctor in the hospital as their doctor. Even after they're discharged, they kind of have that identification with them. So just a thought going forward. Any other questions? Hello? Okay, at this point, I think we'll close. I'd like to thank everybody for attending. Tim Richmond, thank you so much for your presentation and your time put in for this presentation. It's really been excellent. I'd like to thank all the people that joined us today. Your feedback's important. If you would like to hear other speakers or discuss other subjects, please let us know. We'd like your input. You can reach us reach us through Maria Fideli at Fideliem at remedymedicalservices.com. That's FEDELEM at remedymedicalservices.com. You can also listen to a recording of this presentation by going to Remedy Medical Services and clicking on the webinar link. Appreciate everybody's time and effort. I hope you all have a good day and a good upcoming weekend. If you have any further questions, you may reach me, Bob Johnson, at 715-834-1555. Thank you very much. We're signing off.